Next is Professor Ian Abbs, who's the Chief Executive Officer at Guy's and St Thomas's NHS Foundation Trust, very distinguished clinician in his own right and a very dear friend. Ian, thank you very much indeed.
Well, thank you very much, Lord Kakar, and thank you for the invitation to talk at today's important conference. I'm going to do a bit of problem articulation before colleagues come on to perhaps suggest some solutions, and I'm sure that will be a vibrant conversation today. But we have a problem. And health systems globally, for about the last century, have been, the equations around healthcare have been stable. And those equations basically have two components. There's demand side components, supply side components, and on supply side, the big factors are the amount of money that goes into a system and importantly, the human capital that provides care. And put straightforwardly, in the majority, if not all, high GDP countries, that equation is broken. Whether it's the US, Europe, elsewhere, those equations are now unstable equations. And it's not actually the money that goes into healthcare that is the most broken factor. That's a political choice. It's the workforce component. We are simply consuming too many people in economies in the delivery of healthcare. And we've got to do something about it. The factor that will keep those equations stable is the conversation we're having today. It is how do we innovate, how do we bring new ideas and new technologies, particularly to replace people in the equation, so that we can continue to deliver high quality care, but at a stable unit cost, but without consuming the human capital that we do now. Where in the US, for example, the healthcare sector is bigger than retail, bigger than manufacturing as a consumer of human capital. How does that problem manifest? I'll just, a couple of slides on what is the problem, what's the scale of the problem. So you will all have heard of the signal that is a marker of an unstable system, and that is in the UK the wait list number. So that picture on the left of the screen shows you the rise in wait lists over the last few years, particularly accelerated by the pandemic, but on the way up before the pandemic. And astonishingly, it's astonishing really, that people are waiting in those red groups for more than a year for care. And that's unheard of going back 15 to 20 years. And is an astonishing signal and really, I think, does say that we have something to do. And at the end of each patient pathway is a person waiting for care. And we simply have to grasp this agenda now, because that is an unacceptable picture. Is it political? It is. Had that slide worked, the first picture on the slide is actually the political framing. The political framing is, whereas historically amongst voters, the economy, security, other aspects were right at the top of the political agenda and won or lost elections. The situation now, put simply, is that the future of the NHS in this country is certainly the second and occasionally the first issue on the minds of the voters, and they're the first issue in the minds of politicians. And there are no easy answers. Many of you will have read Lord Darles's recent report, referenced very heavily in the run-up to the election, around the NHS being broken. I don't think it is broken, and that's actually the conclusion of Lord Darcy's report, but it is significantly bowed. And we've got to do something to reverse that position and make the NHS, which is the largest by far provider of care for patients in this country and is the provider always of last resort, often for the most complex care, we've got to make that sustainable. Lord Caker and I were at dinner recently, we were discussing some of these problems, and if we can solve this problem, it is worthy of a Nobel Prize, because this is a global issue. Actually, I was thinking about which category that might be in. I think it's actually the Peace Prize. Because if societies break down on the basis of access to a basic human right, which is healthcare, if we cannot provide healthcare for the poorest and the least served in our societies, then they have a right, I believe, to see that as a reduction in their human rights. And there lies conflict. So I would argue that if there is a Nobel Prize, and I think there should be one for this, it's probably the Peace Prize. However, there is some hope, and I'm sure, as we'll discuss today, that equation can be rebalanced by the use of innovation and technology. But there's a problem there too. I won't go through this, but there are a number of areas where innovation and technology can make a difference. And certainly, we have many current business-as-usual processes that could be revolutionized by new technology, particularly artificial intelligence. There's a fantastic product coming onto the market by Hippocratic AI that replaces people in the management of long-term conditions with navigators using bots. But actually getting them into, as our previous speaker mentioned, adoption is a big problem. And there are certainly more innovative and disruptive technologies that could also come in. And quite clearly, we are going to need to focus on purpose and impact. There are a lot of brilliant technologies coming, particularly for direct patient care, artificial intelligence in image analysis, for example. However, if you accept the statement that healthcare is a logistics business, it's getting the right patient in the right place for them with the right data, and that's a big question, where the minimum clinical resource gives the patient the outcome they want. A lot of those are transfer steps. A lot of those are process steps. And there is as much to create value. There's as much value to be created, probably about 60% of the value equation, in the processes of care as much as the direct delivery. I'm a clinician, going back quite a long time. The care that's delivered now is pretty similar, really, in its processes to the care that was delivered when I trained some few years ago. But actually, it's not that dissimilar from the care that was given in 1860. Outpatient, we've got an outpatient clinic that was designed probably in 1860 when St. Thomas's opened. It's pretty similar, actually. And the processes of care have not really changed in generations, and that now, though, is the time. But we've got to prioritize areas for deployment, importantly in social care as well as in healthcare. We've got to develop new structures and incentives, and I'm sure we'll speak quite a lot today about incentive models that promote adoption. There is no shortage of invention in this country. There is no shortage of innovation. But we have a terrible, terrible track record on adoption. When I used to chair Digital Health London, a number of colleagues are here today from that, the accelerator, the had a great accelerator. It's been going for a number of years now. It's a fantastic opportunity for companies. The number one question at the engagement day for new companies joining the accelerator was, how do we penetrate the NHS? How do we get in? And many of their models, the mental model that companies have of the NHS is of this large, slowly moving, quite fat, blubbery animal, like a whale. And the mental model is harpoon the whale, you've got the whale. It's not like that. The NHS is much more like a shoal of fish. It's got many, many individual organisms in the shoal. Most of them are swimming the right way, some are swimming backwards. And when you spear one fish, you've got one fish. So we have a fundamental N of one problem at the moment. So we've got to do more about adoption and, importantly, scaling. So models to scale innovation are what we desperately need. So and I'm sure we'll talk about that as well. And important, of course, that those are equitably distributed. I'm not going to talk through the risks, but there are risks, and we have to look into them. But I'm also pleased to be part of the UK's Responsible AI Council. There has to be some conversation about regulation, clearly about AI. But I would argue the counterfactual, if we don't do something using these new technologies, then we already are holding significant risk. The first slide was an illustration of that. The risk in that 7.5 million people waiting for care is significant. I'm not going to go through this slide, but I think if we can deliver this future, then we can deliver better, importantly faster, and importantly fairer healthcare for all. So I'm going to close there with the problem articulation, but I think as a call to arms, Lord Caker, I think this is an important day because it's a call to arms for us to come together as a community to solve that fundamental equation that if it persists as broken, will lead to the disruption of society. I truly believe that. So thank you for your attention. I look forward to contributing to today.
The Harley Street Health District, the home of healthcare since 1860.